But what's really important is that people do not do GLP-1 receptor agonists, these GLP-1 weight loss medications alone.
Diary of a Kidney Warrior podcast in partnership with Kidney Care UK, sharing faith, knowledge, hope, and love.
Hi, and welcome to Diary of a Kidney Warrior podcast. I'm your host, Dee Moore. This podcast is a space for honest, informed conversations about living with kidney disease. This is part 2 of our Beyond the Scale series. In this episode, we're focusing specifically on GLP-1 medications, how they work, and what they mean for people living with kidney disease who are navigating weight management and kidney transplant eligibility. If you haven't yet listened to part 1, I recommend starting there, as we explored how BMI and weight can influence transplant pathways and the emotional realities many patients face. If you're joining here because you're specifically searching for information about GLP-1, you're in the right place. I'm joined by Dr. Adrian Brown, Associate Professor in Nutrition and Dietetics, NIHR Advanced Fellow, and Senior Specialist Weight Management and Bariatric Dietitian, who helps us unpack the science, the evidence, and the practical considerations around GLP-1 treatment. As always, this episode is for educational purposes only and is not a substitute for personalised medical advice. Please speak with your renal team before making decisions about your care. Let's go. Let's talk about GLP-1s. I mean, there's a lot in the media. GLP-1s have exploded across the world, really. Everyone's talking about GLP-1s. We've all seen different celebrities, transformation using GLP-1, and there's a lot there. There's a lot of people buying it off the internet and different ways of accessing it. There's a lot of talk about GLP-1. So let's really get into that. What are GLP-1s?
I couldn't agree with you more, first off, about the explosion that we've seen with these medications. I've been in obesity management for nearly 2 decades now, so I've seen a huge change over this time. And it's only been more recently that we've started to get these currently injectable medications. We're moving on to actually oral soon of these drugs. So let's firstly define what we mean by these medications. GLP-1s, what are they? So they are obesity management medications. They come in the form that you'll know, Ozempic, Wegovy, or Mounjaro. They're different types. And they are what we call incretin-based therapies. And I'll explain why we're talking about that now. Now, when you eat, there's hormones that are released from your stomach and your bowel that impact on your fullness. So there's particular hormones. One of them is called GLP-1 or glucagon-like peptide 1. That is your GLP-1 agonist. That's your medications. And there's other hormones called what we call GIP or glucose insulin-trophic polypeptide, long words, but appreciated that we've got these 2 hormones that go to our brain and make us feel full. Now, in your body, these are broken down incredibly quickly, within minutes. So they go up and they go back down. That's how they're designed. What the drug companies have done is they've slightly altered that hormone to mean that it stays around for longer in your body. Initially, it stayed around for hours, but now it can stay around for a week, and that's those once weekly. So that's things like your Wegovy and Mounjaro that stick around for a long period of time, and they have a significant impact on both your hunger and how full you feel. So what they do is that they work on your biology, just like a hypertensive medication. So you take a drug to manage your blood pressure because you are struggling to manage that. And many people with kidney disease are on 1 or 2 or even 3 medications for their blood pressure. And this is doing the same thing. So it works on our brains and our stomachs to make us feel less hungry and also fuller between our meals. And so what we've seen from the data is that they've been incredibly beneficial for helping people, firstly, to lose weight. So some of the medications now are achieving over 20% weight loss, but also they're improving on health. And in the studies that have looked at kidney disease specifically, and the biggest one we have at the moment is called the FLOW trial, that actually showed using one of these medications actually helped to reduce the incidence of kidney disease events. So the progression to kidney failure, but also the reduction of your kidney function actually helped as well. So we're seeing that they could potentially have some real benefits, but the evidence in kidney disease at the moment is still relatively limited. There's lots for people with type 2 diabetes and working on obesity, but obesity, diabetes and kidney disease, there's less evidence at the moment. But we are seeing some really good outcomes.
So this GLP-1 hormone, is there any evidence that people who are overweight or living with obesity, that they lack this hormone than people who aren't overweight or living with obesity?
That's a really interesting question. So there has been evidence looking at the difference between people of a lower body weight and the people of a higher body weight. And what we see from the literature is there's a few changes that we see. So there is your GLP-1, which is your satiety hormone, and there's other hormones that link in with satiety. There's one called polypeptide YY or PYY. And what we see is that after people eat, they release less of it when they live with obesity. But also there's another hormone as well. That's called your hunger hormone. It's called ghrelin. It's released from your stomach. So when you come to your meals and you feel hungry, part of the reason is that your ghrelin, your hunger hormone, is risen. So when you eat, your hunger hormone drops back down. What we see is that in people living with obesity, there's less suppression of that ghrelin. So they feel subjectively hungrier. But also what's really important to understand is that when people lose weight, your body responds to that weight loss. And what it does is it has a response, we call it counter-regulatory response. So it in essence, it attempts to make you weight regain. So what it does is when you lose weight, compared to if I measured you before weight loss and after weight loss, your ghrelin would be higher. So you're producing more hunger hormone. And that doesn't just stay for the weight loss period. Even if you weight regain, at a year later, that ghrelin will likely remain higher. In addition to that, what we see is that in the short period, it impacts on the release, both in the fasted state, so when I don't eat food, and after I eat a meal, related to the release of GLP-1 and also that PYY. And a year later, that PYY is still lower than it was before weight loss. So that responds by making people feel hungrier, not just in the short term, but despite weight regain a year later, and have a greater desire to eat. And so often this idea returns back on this idea of weight stigma, where people say, well, you should just have the willpower. You should just be able to maintain that weight loss. But actually, your biology is working against you. And this is what these medications are helping with. They're helping to address this issue where biology is playing against people. But what's important to understand with these medications is if you come off them and stop them, from the data that we have, the average person would gain around 2/3 of that weight that they have lost back. And that's related to these hormones and that appetite. So it's not I just haven't managed to stick with my new lifestyles or I've changed my behavior, although they are incredibly important for long-term change and they can help a certain group of individuals to maintain that weight loss. But there is a chance that if you come off the medications, just like if you stopped hypertensive medications, your blood pressure would go back up. We see exactly the same with these weight loss medications.
So how do you combat that then? Because like you said, for any other condition, it's viewed as ongoing. You wouldn't just suddenly stop heart medication or hypertension medication or any other medication. But if there isn't that recognition that living with obesity is also a medical condition as well, it's kind of dooming people to that lose gain cycle then. I mean, how do you combat then? Is there currently an ongoing plan to be like microdosing or having smaller doses of the medication to help people maintain this weight loss? I mean, how do we combat this?
It's a really interesting question. And one of the questions that many of us in working in obesity are thinking about at the moment. I was at a meeting last week and we were discussing these medications and this exact question came up. And I think ultimately, just like any other long-term condition, and obesity, as we said before, is a chronic, relapsing, progressive condition. You could call it a disease as well because it meets many of those characteristics where it impacts on health and other organs. And ultimately, just like hypertension or diabetes, these medications, in theory, should be considered for long-term use. Now, at the moment, we don't know how best to give that long-term medication. Is it at the maximal dose, i.e. 2.4 milligrams for Wegovy or 15 milligrams for tirzepatide or Mounjaro? Are those the doses? We don't know whether it's about coming down to the most effective, minimal effective dose. I'm able to maintain my weight here and this is the dose I'm at. There are protocols, as you will have heard, you mentioned microdosing. We don't have the evidence for that. So individuals might be on the internet talking about microdosing. I take small amounts and this is what I do, but it's not something that currently there's the evidence for. So we're still in a bit of a grey area, particularly around this, is that what's happened is we've got these wonderful medications and the research is slower than what's happening in clinical practice. And so lots of things are happening and lots of things that people are doing in clinical practice that we don't have the evidence. So for me to suggest all these other dosing regulations, we don't have the evidence at the moment. That evidence will hopefully come. But ultimately, the things that we need to be thinking about is we need to be thinking about obesity as a chronic relapsing disease or condition and treating it that way. So once people have access to care, that needs to be lifelong, like it is for kidney disease or diabetes. We need to be thinking about the medications being managed in the same way, but also support in the long term. Because we know the issue often, and this is my personal experience with patients, is that patients come to me and they say, I've lost weight. I've lost stones of weight in the past, but then I've put it all back on. And so often it's not about weight loss. It's about weight maintenance, which we've just learned is challenging because of the changes in biology, but also the fact that when we look at how obesity is cared for, the programs are limited to either a 12-week online program or they are limited to 1 year or 2 years maximum in a specialist service, which we would recommend. So ultimately, what we would suggest is that there needs to be specialist oversight. So people should be referred to a specialist service to support with their weight management. So this would include dietitians, psychologists, medics, ideally physical activity individuals to help with physical activity experts, and to provide patient-centered, individualized, but also compassionate care in the long term. But we still have a long way to get to that, both in those without kidney disease, but also those with.
So for people with kidney disease, I mean, I've heard that some people, they really want to get the medication and they may lie to get it, or they may get it off the internet. What is the danger of doing that, especially as a kidney patient?
As I sort of reflected to earlier on, there's challenges by getting these medications from other sources other than your healthcare professional. Firstly, unless they are a registered prescriber, you've got to make sure you get the medication you are paying for. And there have been reports of people not selling the medication that it says. And so you need to be mindful of going to someone who is reputable and is official. So making sure they're registered as a healthcare professional. What's also important is that you have wraparound care. So you have access to not just the medication, but you have access to a dietitian, to potentially a psychologist, but also an exercise professional as well. Now, the reason that we're saying that is that these medications have significant impacts on your appetite. And we've noticed that individuals have significant reductions in their energy intake, and some individuals are managing as little as 800 calories a day or less, one meal a day, for example. And within that means that you're not getting the protein for someone with kidney disease. You're not getting the vitamins and minerals to make sure that you stay healthy, but also it could potentially impact on your fluid as well. And so what's super important is you don't do this alone, because you need to have that expert advice to give you advice on how to manage this. The medications also have side effects. So they have gastrointestinal ones. So they affect our gut particularly. It's how they work. And so you might get experiences of nausea, of things like sickness and constipation. And so that can impact on how much you eat, but also impact on your bowels. So they need to be managed. And they are usually relatively moderate or mild in their presentation. They can be severe and they need advice. So healthcare professionals can help you manage those issues, looking at fiber, looking at managing the nausea with dietary recommendations, avoiding high fatty foods, for example, maybe fizzy drinks, but also having some carbohydrate to avoid the nausea, which people might be avoiding because they want to lose weight. In addition to that, what we see is that when we look at people on dialysis, we notice that they become what we call catabolic. So they burn their muscle more. But when we look at the weight losses in using these medications, we can often notice that they actually lose more muscle mass than, for example, on a diet. So when you lose weight, Dee, what you do is you don't just lose fat, as our minds go, we also lose muscle. So the expected weight loss ratio that we have is 3 parts fat to 1 part muscle. So that's 75% fat, 25% muscle. Now, from the evidence that we have from some of these large trials in people with obesity, is that we can see that up to 40% of the weight loss is muscle or lean tissue. So it's higher. So with the dialysis patients and those with more advanced CKD, that presents a real risk about them losing muscle mass and then making them more at risk. And so that's where the healthcare professionals can come in to support you around that protein and minimizing it. So protein presents a very important part, and so does physical activity and particularly resistance work to minimize that lean tissue loss. But protein intake varies across different stages. So those on dialysis need more, those before dialysis need slightly less. And so it's important that you speak to your healthcare professional to get that advice, to be able to manage that. But also, if you're eating less, how do I manage that protein? How do I manage the vitamins and minerals? And how do I manage that muscle mass loss or the vitamins and mineral losses or reductions to make sure that I lose weight in a healthy way? And that's why avoiding doing this alone, getting support. But if you are with kidney disease, you need specialized support. So make sure that you speak to your team.
So, as a kidney patient, how easy is it to access the GLP-1 medication?
See, that's a really important question. So tomorrow, can you go to your team and ask for the medication? Now, these medications are prescribed for two different reasons. They're prescribed for diabetes. That's where they first came out, because the GLP-1 really helps with blood sugar control. And then you've got medications that are specifically designed for people living with obesity. So many people who are listening today might be living with diabetes. And one of the medications that you could potentially get access to are these GLP-1 agonists. So things like Mounjaro and Ozempic. Now, for weight loss, those medications are slightly different for obesity. So that for weight loss only, not for diabetes, it's called Wegovy. That is the Wegovy. That is the higher dose. And then Mounjaro, that is tirzepatide. And again, those higher doses. And so what we are seeing from the data that we've collected is that individuals with diabetes are potentially having access to them. But people that aren't living with diabetes, let's say living with hypertension or obesity only, are finding it more difficult. Now, more recently, you will have seen, probably in the newspaper, that NHS England have put on a plan to get access to these medications within primary care. You would have seen, go to your GP and get access. Now, when they did the initial look at these medications and whether they should be offering them, what they did is they looked at how many people would be eligible for them. And what they discovered is that there would be over 3 million people who would be eligible if they just did the simple sums. And they said, in order to make sure that people get access to them, we want to do a staged process. In order to do that stage process of bringing it into practice, they decided to change the criteria from the National Institute for Clinical Excellence, that's NICE, that recommend these medications should be for a BMI of 35 or greater and one obesity-related condition. What they changed it to allow this stage process, they changed it to a BMI of 40 with 4 comorbidities. So, to get it from your GP, you would need to have hypertension, you need to have hypertension, obstructive sleep apnea, high cholesterol in your blood. You can have diabetes, but also cardiovascular risk. And if you do not have one of those 4 or 5 conditions, and you need 4 of them, you don't get access to the medication. So if you had 3 of them and a BMI of 40, you could still not get hold of the medication. And CKD is not one of them. So specifically for obesity, taking diabetes out of it, the challenges that people living with obesity and kidney disease to getting access are challenging. Now, there's some excellent programs around the country that are doing pilot schemes around access to them. Some of them are in London. One of them is called KFIT, and it's allowing their patients access to these medications to help them to lose weight prior to transplant. Fantastic program. The challenge is that it's not available everywhere. And getting access to those drugs that meet those criteria is proving challenging from the discussions we're having with individuals around the country. It's not saying that people aren't able to get access to them. It's just going to be more challenging for certain individuals if you don't meet those criteria. And that stage process with NHSE is over 12 years. So each section reduces down the BMI but keeps the conditions the same, or reduces down the number of conditions and then reduces down the BMI. So those criteria will change over time, and we're hoping CKD will be introduced as one of the conditions potentially, but at the present time it isn't. So you can speak to your clinicians, see if you are eligible. However, there are challenges in getting access to it within local health systems, particularly if you are living with obesity and not multiple conditions.
So for a kidney patient who wants to get on the transplant list and doesn't have those 4 conditions, what can they do? What hope is there for them?
That's a really important question, Dee. And I think those are the discussions that need to be had with their kidney team specifically, because ultimately their kidney team might be able to get access to the medications for those individuals, but that needs to be done on an individualized basis. It's appreciating that actually going to your GP, and this is why I explained it, is that going to your GP and asking for these medications and you have CKD can be challenging because they have those criteria. Now, the thing is that health boards around the country or health systems, might vary that criteria. So you might go to one area and they might say kidney disease is allowed, but you might go to another area and it might not be. So there is variation potentially that's going to happen within the UK specifically. The important thing to appreciate is that the medications are not a cure, and we need a toolbox of options that are available. So firstly, it would be speaking to your kidney team about potentially being referred to a specialist weight management service within your locality. And there are challenges in accessing them, but seeing if you can access them would be the first step. Seeing what support is available within your local service. And also, certain individuals might actually be able to be referred for bariatric surgery. Now, bariatric surgery before was actually one of the only options available for people with advanced CKD and obesity or CKD to lose weight. And bariatric surgery or weight loss surgery still remains the most successful treatment. It's better than the drugs at the moment for both weight loss and improvement in health. Now, although there are benefits of the weight loss surgery, there's also an appreciation that they present some higher challenges in people with CKD, and particularly related to sort of higher surgical risks, particularly those that potentially on dialysis, etc. There is impact on potentially wound healing and infection risk, and also managing the electrolytes, and your hydration after surgery. And so what's really needed is, if you're planning to have bariatric surgery or weight loss surgery, you do it under the communication and the connection of both the weight loss surgery team and your kidney team. Please do not get on a flight and go to Turkey and get a bariatric surgery operation. This needs to be done in a safe way with experts that are able to manage you. So surgery could potentially be an option if you meet the criteria and you go through those processes. But ultimately, we need to be offering people a wide variety of different options, including diet, physical activity, the medications, and potentially certain individual surgery to basically help as many people as possible.
So with all these different options in mind, how can we as patients advocate for ourselves if we feel discouraged or judged?
That's a really important question, Dee, and really comes back to our topic earlier on about weight stigma. What's incredibly important is to realize that your value is not related to the weight on the scale, and your value relates to many other things in your life as well. We should be focusing on health and not necessarily weight all the time. How is my health? As opposed to a number of the scale, as we said, can be challenging, particularly for those on dialysis. Realizing that it's not a personal failure related to your body weight. And there's lots of factors that influence, as we explained earlier on, related to you living with a higher weight. I think when we are advocating for ourselves, it's about speaking to our healthcare professional, firstly about the language we prefer to be used when particularly talking about weight, but also talking about the approach that works best for you to help you to achieve the goals that you wish. So, for example, I spoke to someone recently who needed someone to be accountable to. But that accountability needed to be in the right way. So not being blamed or shamed about not achieving the goals. It's really about the positive reinforcement that they needed, saying, well done on doing that. That's great. You're doing a really great job. Have you thought about? Not, you're not doing it. You should be trying harder. So appreciating how you as a person likes to be approached, and then speaking to the healthcare professional that you have to say, this is how I would like to have these conversations and for you to support me in this journey. And part of that is about right at the start, explaining to people what you would like to get from speaking and seeing that individual.
I think that's really important. It makes all the difference. I'm always talking about bedside manner when I'm talking about my experiences of health professionals, and I think having we talk about love language, so I guess having your patient communication language recognized. I like the gentler soft touch, or some people do like the drill sergeant. My PT, he'd whack you with the foam. It wouldn't hurt, but it was like, come on, get on with it. But it motivates you to keep going, because even though it didn't hurt, you don't want to get whacked with it. But I think when it comes to healthcare, sometimes we forget that we do have a choice in terms of we can say, I would prefer if ... and it is perfectly reasonable to ask for these things. So I'm all for it, definitely.
This is meant to be a collaboration. This is not meant to be a one-sided conversation where health professionals simply give information and expect someone to do it. This should be collaborative, where both parties discuss goals under an agreed umbrella and come to an agreed decision, as opposed to being told, this is what we want you to do. And particularly when it relates to weight. And obviously there'll be situations in those that have kidney disease where there are needs to, we need to do this for your safety. But when we are talking about discussing goals related to health and weight and those sort of things, there very much needs to be a collaborative approach on both parties to be able to manage long-term change.
So I agree totally, because the way I word it is for and with. I don't want care to be done for me. I want care to be done with me. And I really think that, as you said, collaborative working is the best way forward and builds a much better relationship and rapport between patient and clinician. So absolutely, as I always say on the podcast, advocate for yourself. Don't be afraid to ask for these things, because it can make a massive difference in terms of the outcome of your care.
Great. And I love that, Dee. I love the for and with. I might take that to my next consultation to say we're going to be working with you as opposed to doing things to you. Yeah, great.
So today, Adrian, we have discussed the topic of beyond the scale, navigating weight, dialysis, transplant eligibility, and GLP-1s. You've shared so much information today that I know is going to help so many people. I would just want to ask one final question. And my final question is, what is your final words of encouragement for the listeners?
Dee, firstly, thank you so much for inviting me today. I've really enjoyed our chat. My final thoughts are, and I've said it before, is to be compassionate with yourself when things are challenging. Give yourself a break. Don't blame yourself. Think about what you need from your team, from your family, and advocate for yourself to get what you need from that support network and your healthcare professional. And ultimately, remember, find something you love doing and continue to do it.
Thank you so much for joining me. Thank you so much for all the information that you shared today. I know this is going to help so many people out there, and it certainly helped me. Thank you so much.
Right. Thank you so much, Dee.
As we close this two-part conversation, I hope it has helped bring clarity to a topic that is widely discussed but often misunderstood. GLP-1 medications are trending, but when you're living with kidney disease, decisions around weight management and transplant eligibility are deeply personal and must always be guided by your healthcare team. There is no one-size-fits-all answer. If you're listening or watching part 2 and haven't yet heard or listened to part 1, I encourage you to go back and check out part 1, where we explore the wider context around weight, BMI, and transplant pathways. If this discussion has been helpful, please follow or subscribe to the podcast so you don't miss future episodes. And if you know someone navigating dialysis, transplant eligibility, or considering GLP-1 treatment, please consider sharing this episode with them. The more informed we are, the stronger we become as a community. Until next time, take care and choose to live.
Diary of a Kidney Warrior podcast in partnership with Kidney Care UK, sharing faith, knowledge, hope, and love.